1 of the House of Commons Standing Committee on Health. In accordance with our routine motion, I'm informing the committee that all remote participants have completed the required connection tests in advance of the meeting. Pursuant to Standing Order 108 Sub 2 and the motion adopted on November 8, 2023, the committee is resuming its study of the opioid epidemic and toxic drug crisis in Canada. I'd like to welcome our panel of witnesses. We have here with us in the room Jennifer and John Hedican. Online, Dr. Mark Vogel, Chief Physician, Division of Substance Use Disorder, University of Basel Psychiatric Clinics. Also by video conference, Kim Briere-Charret, Project Director on Psychoactive Substances pour l'Association pour la Santé Publique du Québec, et Marianne Dussereau, Attorney and Head of Legal Affairs pour l'Association. And also with us in the room, Chief Tan Trong, the Chief of Police for the London Police Service. Thank you all for being with us. We're going to begin with your opening statements of up to 5 minutes in length. We're going to start with the Hedicans. Mr. and Mrs. Hedican, welcome to the committee. You have the floor.
Hello. Thank you for the opportunity to speak to you here today. We lost our oldest son Ryan when he was 26 and our nephew Justin when he was 38 to organized crime's toxic supply of drugs. And as hard as it is, try to imagine losing your son or daughter and then know that over 47,000 Canadians have died the exact same way to the same cause as your loved one. And then have to listen to our political parties choose not to acknowledge that these deaths are preventable if they implemented different policies. Ryan and Justin and the vast majority of Canadians who have died to toxic drugs since 2016 would be alive today if they were alcoholics or alcohol users, as we provide a government-controlled, safe, and legalized source for those substance users. And shame on our federal leadership and elected MPs for choosing to ignore this truth and reality. And shame on those elected politicians that continue to politicize a health crisis, one that has killed more than the Second World War. And for all political parties to choose to ignore this reality disrespects and minimizes Ryan's and Justin's death, our family's grief, and the 47,000 lives lost in their family's grief. These mass poisonings would not happen to any other demographic. We would not allow 22 people a day to die to the same cause year after year and not acknowledge what would save lives. The prohibition of drugs is the single biggest contributing factor in all toxic drug deaths, as it ensures and supports organized crime as the only supplier in every town and city in our country. And we have wasted trillions of tax dollars funding a war on drug users, our family members, our friends, our colleagues. And for more than 100 years, it has been an absolute failure. Prohibition can't keep drugs from flourishing in our prisons. Prohibition has directly created and supports a powerful multinational black market for organized crime that supplies and poisons innocent substance users. The prohibition of drugs is a fantasy policy wishing it could keep drugs from entering our communities, while the reality is that substance use is a normal neurobiological impulse that will always exist in humans. And legalization is the only policy to directly stop our loved ones from dying from toxic drugs and to address reality, just like legalizing alcohol and marijuana has. And for political parties to only call for safer communities, more recovery, and mental health beds, forced and voluntary care, and they choose to not acknowledge all these serious and costly issues will not change a thing until we address the cause, organized crime supplying toxic drugs. Our son Ryan had been in recovery twice, the second time for 8 months at a facility in New Westminster called The Last Door, and returned to work as a third-year electrician. Ryan relapsed shortly after returning to work and died during his lunch break on his job site. Relapse is a normal component of the disease of addiction, and when this happens, our federal drug policy forces those who fight a disease back to organized crime to get what their body demands. And what other disease would we allow organized crime to fill a prescription? The major foundation of most recovery facilities is of abstinence only, rather than harm reduction, which again doesn't address the reality that addiction is not a choice, but rather a disease, with a 92% relapse rate for those using opiates. Recovery played a major part in Ryan's death as his tolerance was low to his 8 months of sobriety when he relapsed. Recovery needs to be based on more than a faith-based 12-step program that was introduced over 90 years ago. Science and medical intervention need to be funded to address and cure addiction. And what other disease do we treat the same as we did 90 years ago? The politicians that call for recovery as the be-all and end-all are choosing to ignore the truths and realities of recovery. It does not address, nor will it stop the deaths of youth, first-time and recreational users, as they are not addicted. It's like these thousands of people somehow don't exist. And recovery will not save all chronic users for many reasons, just as all alcoholics do not enter into recovery. Do not acknowledge these lives is morally wrong, a failing of responsibility, and once again is showing all lives are not equal or matter to politicians. Votes are valued over lives. Our BC Provincial Health Officer, Dr. Bonnie Henry, stated this summer that prohibition is responsible for the death crisis we are in, and legalization and regulation minimizes harms. As an epidemiologist and health professional, her recommendations are based on evidence and science. Political parties base policy and recommendations on the net gain of votes. Our son Ryan, along with 47,000 Canadians, have died to toxic drugs supplied by organized crime, which is supported by the prohibition of drugs. What else do you need to know to stop this mass poisoning of preventable deaths? Thank you.
Thank you, Mr. Hiddekin, and please accept my condolences and those of the committee on the tragic loss of your son. Next, Dr. Mark Vogel, Chief Physician, Department of Substance Use Disorder, University of Basel. Bienvenue au comité, Dr. Vogel. À vous la...
Welcome to the committee, Dr. Vogel. The floor is yours.
For the opportunity to appear before the Standing Committee. It's an honor for me in particular because I have a long-standing connection to Canada ever since I spent a high school year in Alberta in the early 1990s. As an active clinician and researcher, I specialized in opioid and cocaine use and dependence, as well as the treatment of concurrent psychiatric disorders. I currently serve as head physician of the addiction department at the University of Basel, psychiatric clinics. Our department provides opioid-assisted treatment to approximately 500 patients. In addition, we offer inpatient as well as outreach treatment and provide medical services at Basel's 2 supervised consumption sites. Canada is currently grappling with a severe opioid overdose crisis that is devastating communities across the country. In 2015, I had the opportunity to spend several months as a research fellow at the UBC, and I was struck by how deeply the opioid crisis is affecting individuals and society as a whole. Switzerland, too, faced a public health crisis related to opioids in the 1980s and 1990s. Intravenous heroin use was the key driver of the HIV epidemic, which hit Switzerland harder than any other European country. Open drug scenes were visible in all major Swiss cities, and per capita overdose deaths reached the highest levels in the world. Switzerland's political system is based on compromise between linguistic regions, urban and rural areas, and political parties across the spectrum that have to share governmental responsibilities. Laws are often subject to political referendums. Overall, our political decision-making processes are slow. However, in the early 1990s, the urgency of the situation was so great that politicians, law enforcement, the treatment system, and individuals who use drugs, along with their families, came together to completely overhaul Switzerland's drug policy. The result was the introduction of harm reduction as a 4th pillar of Swiss drug policy, alongside prevention, therapy, and law enforcement. Harm reduction measures, such as supervised consumption services, needle and syringe dispensing, and low-threshold social initiatives like supported housing, employment, and free meals were implemented on a broad scale. Importantly, this was accompanied by the introduction of patient-centered low-threshold treatment for opioid dependence. Opioid agonist therapy with methadone became easily accessible, covered by mandatory health insurance, and available nationwide, primarily in general practitioners' offices, but also specialized institutions like ours. Patients have always been involved in decisions regarding their treatment, and most unnecessary regulations and restrictions were abolished. For the majority of patients, take-home methadone was introduced. Despite these measures, it became clear that a portion of the opioid-dependent patient did still not benefit from treatment. And this is why Switzerland introduced heroin-assisted treatment in 1994, providing pharmaceutical heroin under medical supervision, embedded in a therapeutic environment that includes addiction and psychiatric care, as well as social support. Heroin is prescribed for injection as well as in the form of tablets. Currently, we are also investigating the prescription of nasal heroin in a national multi-center study. It's important to emphasize that heroin-assisted treatment is much more than just dispensing heroin. It is a comprehensive, interdisciplinary, and cost-effective treatment approach that also addresses psychiatric comorbidities such as psychosis, depression, or trauma, which often contribute to addiction in the first place. Up to 80% of patients in opioid agonist therapy in Switzerland have such concurrent psychiatric problems. I firmly believe that opioid agonist therapy can only achieve its full potential when these co-occurring issues are also addressed. All of these measures were implemented on a large scale and made available across the nation. Switzerland, while smaller than Nova Scotia and much of it mountainous, now has 16 supervised consumption services and more than 1,800 patients in 24 heroin-assisted treatment centers. Why is this important? We know that only patients receiving treatment can benefit from it. In Switzerland, around 80% of opioid-dependent people are engaged in opioid agonist therapy, with a range of medications they can choose from on any given day. In Canada, this proportion is much lower. In our outpatient clinic in Basel alone, we treat over 200 patients with pharmaceutical heroin. If we were to translate this number to Toronto, that would imply approximately 3,000 patients in heroin-assisted treatment. However, when I prepared for this meeting, I reviewed Dr. De Villa's recent statement to the committee. She noted that the only injectable opioid agonist treatment program in Toronto has 35 patients. The opioid-dependent population in Switzerland is now an aging cohort, and new solutions are needed to care for elderly patients. The number of new opioid users has declined steeply since the 1990s. The provision of heroin-assisted treatment has been confirmed in 5 popular referendums, and problematic opioid use is viewed as a medical issue, leading to a reduction in stigma around this treatment. We're convinced that this is the result of the broad introduction of harm reduction measures and low-threshold opioid agonist therapy, including injectable options and treatment of concurrent disorders. Thank you for your attention. I'm happy to answer any questions.
Thank you, Dr. Vogel. Suite de l'Association pour la santé publique.
Next, from the Association pour la santé publique du Québec, we have Kim Brière-Charret, Project Director, and Marianne Dessureau, Attorney and Head of Legal Affairs. You have 5 minutes. Welcome to the committee. The floor is yours. Thank you, Mr. Chair. Hello, members of the Standing Committee on Health. Canada is facing a massive public health crisis because of non-regulated drugs. 47,000 deaths have occurred since January 2016, and this surpasses the number of Canadians who died during the Second World War. This requires a response that would be universal throughout the country. Canada has been identified as a country that focuses on human rights and public health, but our solutions are not enough. We need to do more in order to avoid premature deaths, enlarge access to voluntary treatment, and have a regulated supply and reduce the legal burden. Quebec has been identified as a province that is less impacted than others, but there is still an overdose crisis. Many indicators show that it is getting worse. The province focuses on harm reduction, treatment, and other pillars. The social safety net has certainly helped in reducing the number of overdoses and reducing the pressure on our health services. Looking at social determinants of health is essential. The lack of social housing and resources in certain sectors make the issues worse. We need to work on prevention uphill and manage emergencies. There is an increased pressure when we do not reduce stigma. In 2020, the legal costs related to drug use was up to $10 billion. Resources in harm reduction are often the last resort for people who are hard to reach. Also, brain lesions can increase issues with consumption and increases the number of deaths and complications and permanent complications. Supervised consumption sites are essential in order to offer safe and legal use. Detox and therapy is important, but it needs to be part of a continuum of care. Forced treatment has not shown to be efficient and increases the risk of overdose. We need to have accessible, free treatment that is properly adapted. Prescribing regulated substances also lowers the risk of accidental deaths. Offering medication is not enough anymore for detox. Access to regulated molecules is important for reducing the toxicity of drugs. Overdoses are linked to toxic drugs. This issue is complex, and a report from the United Nations Human Rights stated that it has a higher impact on vulnerable groups. This is based on data, and we can't keep looking at this issue for political ends. Thank you very much.
Ma collègue Marianne Desio.
My colleague Marianne also has some speaking notes, I believe. Would you like to continue?
Marianne, ton micro est baissé.
Marianne, you're on mute. Please go ahead. Apologies. Just to conclude, our Constitution is based on legal matters that we need to factor in when we look into the opioid crisis. Legislation on drugs needs to follow the Canadian Charter of Rights and Freedoms, but also needs to respect the provincial charters, the right to life, to safety, to integrity, and freedom. There needs to be consent for care. These are fundamental principles in our charter. All policies and legislation need to be aligned with these principles. Thank you.
Merci à vous.
Thank you very much.
And last but not least, on behalf of the London Police Service, Chief Tai Trung, welcome to the committee. Chief Trung, you have the floor.
Good morning, Mr. Chair and members of the Standing Committee on Health. Thank you for the opportunity to appear before you today to discuss the opioid epidemic and the challenges we face in London, Ontario with respect to the Safe Supply Program and its unintended consequences. London has garnered significant attention in recent months regarding the Safe Supply Program. While the program is well-intentioned, we are seeing concerning outcomes related to the diversion of safe supply medications. Diversion of regulated medications, including hydromorphone, is a growing concern. These diverted drugs are being resold within our community, trafficked to other jurisdictions, and even used as currency to obtain fentanyl, perpetuating the illegal drug trade. Specifically, we are seeing significant increases in the availability of diverted Dilaudid 8 milligram tablets, which are often prescribed as part of the Safe Supply initiatives. Vulnerable individuals are being targeted by criminals who exchange these prescriptions for fentanyl, exacerbating addiction and community harm. This issue is not isolated to individuals experiencing substance use challenges, but impacts the safety and well-being of our entire community. The human cost of the opioid crisis is devastating. In 2019, 73 individuals in London lost their lives due to drug overdoses. That number spiked to 123 in 2020 and reached 142 in 2021. While fatalities have slightly declined since then, 123 in 2023, we remain far above pre-pandemic levels. Tragically, over 80% of opioid-related overdose deaths in London are linked to fentanyl. Our enforcement data emphasizes the growing issue of diverted medications. Hydromorphone seizures have increased substantially over the past 5 years. In 2019, we seized 847 pills, 75 of which were Dilaudid 8 milligrams. By 2023, seizures had ballooned to over 30,000 pills, with nearly 50% being Dilaudid 8 milligrams. These increases cannot be attributed to pharmacy thefts, as London has had only one pharmacy robbery since 2019. Our police service is working diligently to disrupt the trafficking of fentanyl and diverted safe supply medications. We are targeting individuals and organized crime groups who exploit vulnerable populations and fuel the drug trade. However, enforcement alone is not sufficient. We are collaborating with community health partners to address the systemic issues contributing to diversion. These efforts must be holistic, integrating prevention, harm reduction, and treatment. I'm not here to criticize the Safe Supply program, but to address the serious challenges associated with its diversion. We need innovation to mitigate risks. We need robust enforcement to hold traffickers accountable. We need continued collaboration between health, social service, and public safety sectors to effectively respond to this crisis. This is a complex issue requiring collective action. I want to acknowledge the challenging efforts of health and social service partners who are working on the front lines of prevention, harm reduction, and treatment in response to this opioid crisis. But it will require strong collaboration and also strong enforcement to face this crisis. Thank you for your time, and I welcome your questions.
Thank you, Chief Trung. And we will now begin with rounds of questions, starting with the Conservatives for 6 minutes. Ms. Goodrich, please.
Thank you, and I want to thank all the witnesses for coming here today. And to the Hedekins, sorry for the loss of your children. Chief Trung, you said that there were clearly unintended consequences from this radical new policy of safe supply that was brought in and piloted in your community of London. When you guys put out your press conference and talked about safe supply, how confident were you that the drugs that you guys were seizing was actually from these safe supply programs?
We had direct evidence linking the seizures of Dilaudid 8 milligrams specifically to the safe supply program.
Is enough being done to prevent the diversion of these pills?
There needs to be more. Obviously, we are seeing the diversion of safe supply in London, and that's why it's very important that we work together in the community with our partners and ensure that regulations are in place and that we do our part with enforcement.
We had one doctor here from London, Ontario, Dr. Sarita, and when we were asking her about diversion, she actually talked about the fact that there was some compassionate reasons behind it, kind of indicating that it wasn't just all bad. And she works for London Intercommunity Health, which puts into question whether they actually have enough protocols in place to actually prevent diversion from happening in their clinic. Do you believe that all the clinics in London that are allowing safe supply to continue have enough protocols in place?
Well, we've been working very closely with the executive director, Mr. Cordis, from London Intercommunity Health, and a strong relationship with them is very important, and they've recognized that working together with us and tightening up their procedures and their standard operating procedures is something that we need to look at. We're working very closely not only with London Inter-Community Health, but other partners and stakeholders within the community to see how we can mitigate this diversion.
Would it just be easier if this program were to end? Because it clearly is creating harms not only in the community of London, but ripple effects all across Southern Ontario.
I will say that decisions regarding medical efficacy and public impacts of safe supply or harm reduction strategies are best left with medical experts and medical professionals. My role as the Chief of Police is specifically law enforcement and the efficacy to addressing the criminal aspects that coincide with diversion.
So what is the street price of diverted safe supply in London?
In London, the prices fluctuate. Obviously, you know that it's unregulated. Our last intelligence and information and evidence of Dilaudid 8s, they're being sold between $2 and $5 per tablet.
And that's a substantial decrease from what it initially had been, correct?
Well, in other areas of the province and across the country, including remote areas of communities, that price is significantly higher, the street value.
Okay, to what extent is organized crime involved in the trafficking of this government-fueled opioids?
Organized crime is involved.
The safe supply, you said, is being distributed into other communities. Which communities?
Outlying communities, and we know from information that remote communities in Northern Ontario are seeing prices that are much higher than $2 or $5 tablets.
At your guys' press conference, you said that this has been occurring for a while. Approximately in what month and year did you guys first start seeing the diversion of these government-funded opioids?
Well, I can tell you that it became very concerning and prevalent last year. And we looked at our data for the last 5 years, and the data that I shared with you with respect to the seizures from 2023, where thousands of hydromorphone pills were seized in our city. 50% of those seizures were specifically 8 milligram Dilaudid 8 pills.
So we also had Dr. Sharon Koivu, another London doctor, who said that she saw patients who were vulnerable women that were being pressured to secure safe supply and then basically being pimped out for these drugs. Is this something that the London Police has also seen?
Yes, that's information that we have as well.
Does that concern you, that vulnerable people are being made more vulnerable by the use of government-funded drugs?
Well, our concern is the victimization of all individuals in the community. Vulnerable and marginalized people are extremely at risk. This is a complex issue. This is one area where we see the exploitation of members in our community, unfortunately, are experiencing.
Thank you, Chief Trung. Thank you, Ms. Goodrich. Next, Ms. Kayabaga, please, for 6 minutes.
Thank you, Chair. I should also like to thank our witnesses for being here today and extend my deepest condolences to the Hedican family for both the loss of your son and your nephew. Earlier, you talked about the politicizing of the issue. Do you think that we can find a path forward when the noise is very political right now? And what would you give as an advice to get past the politicization so that we can continue to honor the lives of those who have died?
Sorry.
It was hard to hear you.
Sorry.
I apologize. My voice is a little in and out, but I was just extending my question around your thoughts on the politicization that you talked about earlier, and what would be your advice to get above the noise so that we can actually do the work that continues to save lives?
I believe we all have to come at it from a human perspective. And you can make choices different if you want as government. We've seen it multiple times. Accurate reporting, telling the whole story, understanding that it's not only people that are unhoused that use substances, being accurate in reporting all types of substance users, acknowledging that our First Nation individuals, they're 7 times more likely to die. If we report all of the information, I believe people will have a better understanding. If I can talk to what Layla Goodrich and Chief Ty talked about, I wondered.
Just a second, yeah.
Pardon me?
I apologize, but if you could just be really quick. Would be
Okay,
great.
yeah. I wondered if they asked themselves, why are these people having to sell safe supply? Is it because the other supplies are so toxic? I believe we have to look at it holistically, and we have to stop 10-year-olds from dying with poisoned sources.
Interesting.
Could I
Thank
just
you.
make just one quick.
Just quickly. Yep.
When we talk about politicizing, I just had to listen to Mrs. Goodridge use the word radical. And I don't know why we need the word radical when this harm reduction is brought by health professionals. And it's similar to our federal leader that uses the word drug den when he's talking about safe consumption sites. And it just covers people fighting a disease and shame and stigma. And shame on that language, because it doesn't need to be used. And it does no good.
To what some of our other witnesses have said, that we cannot ignore evidence-based. I'm going to go to the Chief now. Chief, thank you so much for being here. On October 16th, you made a comment in the London Free Press, and you said, we know that we can't arrest our way out of this, but there are times when it is appropriate to make arrests when individuals are openly using dangerous drugs in the community. Who do you think, if you can comment on who would be the appropriate person to make these arrests for public drug use, and what kind of law enforcement services do you think are needed to adequately respond to this overdose crisis in our community, especially in London, and given the context and given the collaborations that have happened across different practices?
And Chair, through you, I will say with respect to your question about the open drug use, police officers need to have the ability to intervene. And when you talk about public drug use and consumption in open spaces, there has to be a balance between the actual circumstance that individual using in public and the balance and the perspective that it has and the impact to the community.
Do you think that the police services right now are equipped to be able to do that?
I think we need collaboration, partnership. We need support from health, social agencies, so that
Is that the collaboration of community services?
That's correct.
Are you currently working with community services to address the opioid crisis in the City of London?
We're currently working with the community, with our community and community partners right now to address the open drug use that is occurring in the city and specifically in the downtown core at this moment. And
Chief, when was the last time your police officers received training to be able to respond to a overdose crisis?
It's part of their ongoing training and annual training. Police officers go through in-service training from an annual basis, and part of that ongoing training involves just that. And we continue to work with our partners and medical professionals to help us perform our duties.
So if you talked about the collaboration that has to happen with community services that are actually trained to help people with the mental health involved and all other things that are involved in a drug use situation. Do you think that police enforcement are the only appropriate people to be at that call, or are you suggesting that there should be other partners at the call?
Let me just state that when I'm speaking about police intervention, I say that, and I've said it numerous times, that when appropriate, only when appropriate, because there will be times when it is appropriate for police to intervene and uphold the law.
Thank you. Thank you both. Suite, Mr. Thériault, pour 6 minutes, s'il vous plaît.
Mr. Thériault, you have 6 minutes. Thank you, Mr. Chair. We have people representing a completely different point of view that focus on harm reduction, law enforcement, and we have parents here as well. I would like to ask a question to Ms. Brière-Charest and to Mr. Vogel. Do you believe that safe supply, in the context of the toxic drug crisis, if there wasn't the safe supply, would the crisis be better or worse? And in your view, what solutions could we find for diversion of the safe supply? Brief answers, please, and then I will ask the same question afterwards to Mr. Trong and to Mr. and Mrs. Hedigan. Thank you for the question, Mr. Thériault. Most overdoses in Canada are linked to contaminated drugs from accidental deaths between January and March 2024 in Canada. 84% were linked to non-pharmaceutical opioids. So that's quite significant. That's why it's so important to have treatment programs with regulated medication, because this crisis is linked to the toxicity of drugs. Regarding diversion, we need to be sure that everyone has access to treatment. Currently, there are people who are waiting so that they can have access to therapy, to different medical treatments. Sometimes they can be waiting for weeks, if not months, and so treatment needs to be accessible throughout Canada. Mr. Vogel? Or Dr. Vogel, rather?
Point out that it's not really clear what's meant by safe supply. There's very, very different programs as far as I'm aware of what safe supply means. Sometimes it can be just a prescription for hydromorphone and nothing else, and I'm not convinced that this will work. But it can also be almost like a treatment setting, and this is where it leads me. I think we should offer medication with opioids as a prescription inside a therapy setting. So this means controlled, this means regularly overseen by a doctor, this means therapeutic contacts, this means a relationship with patients and providers. So I think it should not be apart from a therapy. Concerning, I heard that hydromorphone is used as a currency to get fentanyl. And Mrs. Hedigan was saying that why are these people forced to sell hydromorphone? And this is exactly the point. They are selling hydromorphone because they're looking for fentanyl. And if you want to take the analogy to heroin-assisted treatment in Switzerland, why not treat these people with fentanyl in a really intensive therapeutic setting so they get the substance they are looking for and probably the substance they need at this point in time? And I cannot comment on your question whether it would be the crisis would be worse or better.
Merci, ça répond à ma question.
Thank you. That answers my question. So one solution would be to prescribe what these people are looking for, but in a controlled manner. Chief Trong, without safe supply in a toxic drug crisis, where would we be headed? would it be more significant in London?
And Chair, through you, as I stated previously, the medical efficacy and the public health impacts of safe supply and harm reduction strategies, for me, are best left with medical professionals and public health experts. My concern and my role in the safe supply diversion involves just what we spoke about. Individuals, one issue is that individuals in the
Oui,
program...
ça, on a compris ça.
I've understood that. But would you be for or against what Dr. Vogel just proposed? There wouldn't be any diversion, in his view, if we were prescribing what these people were looking to use. Would you be against the controlled prescription of fentanyl?
Again, and thank you for the question. That decision, for me, is best left with the medical experts. That's not a question that I feel that I should be answering, where my role is public safety and the impacts of criminality involved in the diversion of safe supply.
Merci. Monsieur ou Madame Hedekin?
Thank you. Mr. and Mrs. Hedekin?
Thank you. Safe supply saves lives. And to refer to the doctor, if our alcohol system was still being supplied by organized crime and our alcohol stream was toxic and killing people, we would have to have a safe source for our alcoholics. And if we were prescribing 0.5% alcohol and somebody's looking for a 40% shot of rye, it's not going to work. So that's what we're doing with our safe supply. We have to prescribe what's needed. But at the end of the day, we're losing sight of what's causing what we're talking about, and it's toxic drugs supplied by organized crime.
Thank you,
That's what
Mr.
we need to focus on.
Thank you, Mr. Hedekin. Merci, Mr. Thériault.
Thank you, Mr. Thériault.
Please, for 6 minutes.
Thanks to all the witnesses for being here, and I definitely want to thank John and Jennifer for making the trip from home on Vancouver Island. Again, my condolences for the loss of Ryan. Can you tell us, committee, about your son, Ryan? Can you maybe speak about what your lives have been like without Ryan?
Ryan was our oldest son, and he loved his family, he loved life, he was athletic.
Excuse me,
smart.
Mr. Hedekin. Ms. Hedekin, it pains me to do this, but the rules of Parliament prohibit the use of demonstrative evidence, which we call props. So I'm sorry.
Point of order. Point of order.
We have a point of order from Mr. Doherty.
Mr. Chair, with all due respect, as someone who's lost someone to loved ones to overdose, I'm going to ask for some leniency today. I understand completely their anger, their frustration, and their loss. I don't think we should penalize anybody for doing that.
It appears that your view has some, but not unanimous, support in the room. So I'm sorry for the interruption, Mr. Hedekin. Ms. Hedekin, please go ahead.
Our family IT guy. And Ryan hated his disease, and he felt shame and stigma and remorse, and our political system, the prohibition of drugs, put that on Ryan. And when he tried to fight his disease, he fought hard through recovery, and his second time was for 8 months. And you don't stay in recovery for 8 months if it's not something you want in your life. And at the end of the day, Ryan relapsed shortly after 8 months, doing a job that he loved, that he had dreams, to have that taken away from him when he should be alive today. As I've said, if he was an alcoholic, he'd be here today because he would have had a chance to go to a safe legal source and get what he wanted and get back on that horse again, and he would have beat it. But we never gave him another chance because the prohibition of drugs sends those that relapse and fight a disease right to organized crime. They have nowhere else to go. And we don't acknowledge that, and it's wrong on so many levels. And when I talk about politicizing, that's what happens. We don't acknowledge the truths and realities. There was 150 youth have died in BC from 2018 to 2023. And the vast majority of these kids are not addicted. They make a mistake when they try the gateway drug alcohol, and they die. And we don't talk about what's killed them. And if you two could quit talking when I'm talking up here, it's rude. I'm talking about the death of my son. And 150 youth that have died in our province that would be alive today if they would have had a source that came from a legalized, clean source. And those 150 parents would be disgusted. So I'm sorry, I lost track of that question.
I'm going to follow up with a bit more that you can speak to it. Now, over the course of the study, we've heard from many of the parents who've lost a child, the parents that you talked about, or have a child struggling with addiction. They've shared differing views on whether we need to scale up or scale back measures like Safe Supply. You know, have your views on how to address the crisis evolved since you lost Ryan? What do you think are the most critical actions the federal government needs to take?
Yeah. When you bring a child home from the hospital, you can't look at them with the thought that they're going to battle something that you're not going to be able to help them through. I heard Honourable Minister talk about her children having strep throat, and I understand that because my son had been sick as well. But when they move to use of substances that they battle, or other children have used substances as well, but they don't battle them. Gord asked the question really shortly again, quickly. Oh, so what my view has completely changed. John is an alcoholic, has been sober for 38 years. We talked openly about what substance use was like, and I was certain that our children were not going to follow that same hard path. And I really fought against Ryan using substances, even though I was the mother who would go pick him up if he'd had too much to drink and then not admonish him, because my siblings and my cousins had all done this in their adolescence phase as well. I now know that substance use, when it becomes chronic, is not a choice. The amount of people we met in both recovery facilities that Ryan had been to, the people talked about it might have been their 8th time there. Just the heartache that people had gone through. It's not a fault of the person, even though it feels like it when we put that judgment on them. I really wish we didn't use the word overdose, because it's not an overdose. When Ryan was 16 and had gone to a New Year's Eve party, he ended up with alcohol poisoning. It's called alcohol poisoning, but everything else is called an overdose. We had the coroners change Ryan's death certificate to say that he died from toxicity due to substance. You can't call it an overdose because people are not ingesting what they think they are ingesting. The amount of toxicity in the drugs is so high and so inconsistent that users don't know what they're putting in their body. I hear the word fentanyl. Fentanyl is not the only drug that is being put in that is killing our loved ones. The drug toxicity also is impacting those people that are unhoused because they are constantly in a state of withdrawal in drug sickness. If your coffee that you were drinking today did not have the right level of caffeine but was also replaced with other substances that made you ill, your body would still crave that caffeine and you would probably need more instances of it throughout the day, which is what
Thank
is
you.
happening with the drug toxicity
Thank you,
that's
Ms. Hedican.
happening now.
Thank you. We're over time.
Thank you for allowing
But
that.
I do expect that you'll have other opportunities to expand on that. Next, we're going to go to Mr. Moore, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to all of our witnesses for their testimony today. Chief Trung, I have some questions for you about organized crime, something that is affecting all Canadians, both in urban centers and in rural areas across this country, in every province. And it was astonishing to look at a release from London Police Guns and Gangs section on a recently laying 62 charges. Items seized: Smith & Wesson 9mm handgun, Glock handgun, loaded Glock handgun, another Glock handgun, oxycodone tablets, cocaine, crystal meth. When we see this, and we see that in Canada since 2015, gun deaths have increased by 116%. Gang-related homicides have increased by 78%. And we're facing a crisis related to organized crime. And in your testimony, you mentioned the diversion of so-called safe supply by organized crime. And I'm wondering if you could expand a bit on that. The willingness for someone to divert their safe supply that they've received, or I use the expression so-called safe supply because the testimony that we've heard at this committee is the way that this supply is being abused is resulting in more crime, chaos, and as we all know, over 40,000 overdose deaths since 2015. So could you speak to, in practical terms, how this diversion, in your experience, plays out in your own community?
Thank you for the question, and Chair, through you. I'll give you one example, and I'll first say that not every participant in the Safe Supply program is involved in diversion. I will say that there are instances where individuals who are participants in the Safe Supply program are unhoused, have very little money or currency, who are addicted to fentanyl. As a user, those individuals, these particular individuals in this circumstance, have no money to purchase fentanyl, but they're part of the Safe Supply program. If they are engaged in the program and receive a supply of Dilaudid 8s, that now acts as currency that they never had previously. And because they're prescribed a quantity of hydromorphone, they now are able to obtain fentanyl. So what they will do is trade, sell that medication to obtain fentanyl. That is one example of what is occurring.
Thank you for that explanation. In 2022, Bill C-5 passed. It eliminated mandatory jail time, not speaking here about those that are addicted to any substance, but those involved in organized crime, those convicted of producing, importing, or exporting Schedule I drugs like fentanyl, meth, heroin, and cocaine. The result of that elimination of mandatory jail time for those involved in this organized crime is that it made available the possibility of serving your sentence within the comfort of your own home on conditional or house arrest, rather than a period of incarceration. Coupled with that, in 2019, Bill C-75 came into effect, which has been known as a catch and release system, whereby judges have become increasingly likely, all but a rubber stamp for someone charged with serious drug offenses, including gang offenses, including gun offenses, to be back out on the street to re-victimize their fellow Canadians. So can you speak a bit to the impact of the passage of that legislation and your ability to, and your organization's ability to disrupt the illicit drug trade?
Very brief.
Through you. I will say that as a chief of police, laws are very important, specifically that the laws that are created to ensure that this community is safe, and laws pertaining to individuals involved in organized crime and the exploitation of individuals in our society are very important to me as a chief and amongst many police leaders. I'll also say that Bill C-75, there's a number of perspectives with Bill C-75 and objectives with Bill C-75, many that were not fully mentioned. And the application of the law is not for me to dictate. That is for the courts to dictate and apply.
Thank you, Chief. Thank you, Mr. Moore. Suite Madame Brière pour 5 minutes, s'il vous plaît.
Ms. Bruyère for 5 minutes.
To all our witnesses for joining us today. Mr. and Mrs. Edeken, please accept my condolences on the death of your son, Ryan. When you hear the Conservatives saying that they will stop the safe supply and shut down the safe consumption sites, what are your reactions? Do you think it's important to have harm reduction services available for those struggling with addiction?
Very quick. I'm disgusted when I hear that. It's a gut punch, because only deaths will increase if that was to occur. And any policy that's going to increase death is 100% wrong for so many reasons. It is disgusting. And to call on recovery is what they call for as the be-all, end-all is a fantasy. They're in a fantasy world. And there's 92% chance people are going to relapse. That's their be-all, end-all. And when that happens, as I said, we have to go to organized crime. So until we address reality and toxic drugs supplied by organized crime, you can have this meeting for years to come. And the police chief can keep putting people in jail, because there will always be people to put in jail. And we'll just keep spending billions of tax dollars, and our kids will keep dying.
I wanted to thank you for your question. And I'm hearing people say that nobody's happy about organized crimes supplying of toxic drugs. So you really have two choices. You leave it in the organized crime's hands, because they have been supplying the drugs for forever. I'm sure I could ask you all and or your parents, did you ever use any illicit drugs as you were growing up? Did you ever try any of the things that were illicit? They would say yes, and they were supplied by organized crime. So you really have two choices, Mr. Moore. You leave it in the hands of the organized criminals, or you regulate it and make sure it's a safe supply so people don't die from it. And then you will be able to talk about all the other things. But until then, you are wasting money and you are wasting lives.
Thank you. Thank you so much for this answer. Maintenant, Madame Brière-Charret.
For Ms. Brière-Charret, if we had more time, I would ask if we share any family ties, but I would like to come back to something that you mentioned during your opening remarks, that it's important to look at social determinants of health and other factors. You talked about clarifying these measures and on the consumption of psychoactive drugs and examining the different regional realities. If you could tell us a bit more, that would be great. Thank you, Ms. Brière. Social determinants of health are intrinsically linked to different elements of this overdose crisis. There's research that shows links with social economic factors, housing issues, for example, and there's also a link with poverty and mental and physical health issues, and these are all cumulative factors that can occur with the use of substances. In Quebec, we have noticed that we are no longer meeting needs, but some take measures to avoid being in the streets. But often these issues are caused by social determinants of health and the lack of resources for helping people. And so we need to examine these issues to understand the whole of the crisis at a macro level. And we need to be able to respond to people's basic needs while facilitating access to treatment and continuing research. Thank you. You also mentioned that the safety net had contributed to softening the crisis in Quebec. Do you believe that access to community services, well, I'll let you qualify the access anyway. We're talking about access to essential services for supervised consumption sites that reduce the number of overdoses significantly. These are lives that likely would have been lost without these services. We need to ensure that organizations and health systems can respond to needs and have the resources to do so. And this needs to be done with prevention as well, that needs to be strengthened throughout the country. Thank you.
Madame Brière-Charret. Suite, Mr. Thériault.
Mr. Thériault, you have 2.5 minutes. Thank you. Ms. Brière-Charret, some believe that harm reduction measures, for example, safe supply and safe consumption sites, trivialize drug dependencies. What do you believe of such a view? What do you think of such a view? For harm reduction services, people are there to help those who are using drugs and also offer them additional services, and they create relationships and trust. They build trust with these people. And so we want to focus on the health and the safety of these people to keep them alive. There are people who use drugs, and as was mentioned by Mr. and Mrs. Hedekin, and I would like to offer them my condolences, by the way, but people have always been using substances, and programs based on abstinence alone, whether we're talking about drug use or sexual health, well, they're not effective. Do you think that such opinions contribute to stigmatization? Yes, absolutely. Stigmatization was part of the social determinants, and stigmatization is present in different institutional settings and causes problems with access to services and discrimination. And so we need to reduce stigmas that have an impact on users but also on health professionals.
Merci.
Thank you, Mr. Thériault.
Next, Mr. Johns, please, for 2.5 minutes.
I had a chance to actually visit London and go out with your COAST team. I want to commend you on the work that they're doing, the mental health collaboration work that you're doing on the ground. You talked about evidence-based policies and you support a medical health-based approach. The chief coroner, the chief medical health officers are all saying that people aren't dying from a safer supply of drugs. They're dying from fentanyl, and as Ms. Hedekin talked about, that it's the concoction of fentanyl, meth, cocaine, MDMA. That's what they're finding. 80% of the people that are dying are showing up with fentanyl in their bloodstream. Do you agree with that that's what's killing people?
I would agree that it's the toxic drug supply that is killing people.
So, given that, today here you're talking about safer supply of substances and the concerns around that. I mean, we've seen Alaska, their death rate went up 45% last year. Baltimore's is about 5 times the death rate of what's going on in London, Ontario. And fentanyl, the price of fentanyl's crashed. It's so cheap in those places. Why can't they stop substance use, the death rate going up in those places, and how can you compare that to what's going on in London, maybe?
I can't comment in those jurisdictions. I'm not aware of the actual criminality and the issues that are happening in those jurisdictions.
We know that the war on drugs, basically, this is a North American-wide issue, and it's failed drug policy that's clearly evident. And we heard from the BC Chiefs of Police, we heard from the superintendent, the deputy superintendent of the RCMP. They said there is diversion of pharmaceuticals, that hydromorphone and safer supply is just a fraction of what they're finding on the street compared to fentanyl. And they cited that it's toxic drugs that are killing people. They actually advocated for more safe consumption sites, more safe supply, of course, scaling up treatment, recovery, prevention, and education. Do you not agree with their analysis?
Thank you for the question, Chair. For you, as I've already stated, I am in full support of scaling up prevention, full support of scaling up treatment, full support of scaling up harm reduction. I'm also in full support of scaling up enforcement efforts. So this is a complex issue, as you know, sir. With respect to what is happening, I am focusing on not specifically the Safe Supply program, but I'm focusing on the criminality as a result of the diversion that is occurring, and it is impacting our community here in London.
Thank you, Chief. Next, Mr. Doherty online for 5 minutes, please.
Thank you, Chair. I first want to thank our witnesses for being here. Mr. and Mrs. Hedekin, I know our condolences are little comfort to you, but please know they come from, I share your anger, I share your frustration as someone who has witnessed my brother on the street for far too long, gripped in this crisis, lost a brother-in-law to overdose. While we may differ in our views, I can tell you that my frustration lies with the billions of dollars that have been spent, and yet we still continue to lose people like my brother-in-law, like your son and your nephew. And so I just want you to know that I share your anger and your frustration. I think that there's a better way that we should be doing this. I will direct my questions to Chief Truong. Chief Truong, British Columbia has walked back their decriminalization experiment. We had retired Superintendent Wright, RCMP Superintendent Wright, here last week, who said that the decriminalization experiment was the worst public policy decision in BC's history when it comes to crime and disorder. Would you agree with that? Would you agree that if London was to go forward with decriminalization, that it would increase crime and disorder in your community?
Question, and Chair, through you. I will tell you, as the police chief of London, Ontario, I am not in support of decriminalization of drugs in our community. I am in support of discretion of our officers to have the ability to intervene when appropriate. I'm in support of working together with health professionals, social service agencies to address the root causes of crime, specifically the consumption of drugs and opiates. I will also tell you that when we are talking about the proliferation of public consumption of dangerous drugs in the community, that there's a balance that needs to be considered as a whole to the community, and not just that individual, but you have to look at every individual case by itself through the lens of the social determinants of what is happening. But we cannot take away tools and the ability for police to intervene when appropriate. And there are times when it is appropriate to address situations of open drug use that impact the safety and well-being of the collective community.
Thank you, Chief, for that answer. Would you say, in your view, in London, and perhaps working with your colleagues across our country, are we powerless to stop illicit drugs from flowing through our borders and into our communities?
Sir, I missed that last word you used. Are we what? Sorry?
Are we powerless to stop illicit drugs such as fentanyl, deadly drugs such as fentanyl, from flowing into our communities and our country?
Question, and Chair, through you. I don't think we are powerless. I think more needs to be done.
And the resources. Sorry, would you say that our policing or our police forces have the resources needed to make an impact?
I would say that police services, particularly ones that are experiencing prevalence of organized crime occurring in their communities, require full support and more resources to address organized crime and the crime that is occurring in their community from an enforcement perspective. But it's not just enforcement. Police have to involve prevention as part of the response. And again, the pillars with respect to prevention, treatment, harm reduction, and enforcement, I'm in support of all of that.
Would you say, in your opinion, for crime and disorder and what have you, in London, in your community, which is what you're aware of, would Safe Supply be helping fuel the fentanyl use and deaths and crime?
Thank you for the question. That is not a question that one single answer can be stated. And as I stated,
I can appreciate that.
Sorry, I've stated before, there's one issue of Safe Supply that is impacting the community that I am responsible for, and that is the diversion of Safe Supply. Thank you, Chief Truong.
Okay,
Thank you, Mr. Doherty. Next, Dr. Pawlowski, please, for 5 minutes.
Dr. Vogel, I'm so glad you're here. I've been wanting to have somebody come talk about the Swiss model for a long time. I think what we observe in this room today is a little microcosm of the debate about Safe Supply. where we have the Hedekins passionately advocating for safe supply because it's toxic drug supply that's killing people, and on the other hand, we have Chief Trong talking about diversion, and the concern that diversion creates this very cheap supply of narcotics that may be the entry-level narcotics. And certainly I've heard that from, for example, BC psychiatrists who deal with the population on the streets, and I ask them why do kids start on Dilaudid, and he said, well, they're cheap. The price went from $20 at one time to after Safe Supply came up, it's $1. So whereas a joint is $5 on the street. So what are you going to do, the joint or the Dilaudid? So you start on Dilaudid, and yes, Dilaudid doesn't kill you, but the problem with narcotics is you get used to them and you have to go to something stronger. And that's what's happening, and the concern is people are selling the Dilaudid and then using the fentanyl, and it's the fentanyl which kills people. So what's the answer to balance these? I think, in a large part, it's what's the Swiss do. And Dr. Vogel, if you can just say if you agree with this, the whole basis of the Swiss model is observed treatment, right? For the vast majority of people who are on stronger drugs like heroin, they're not going to be okay with oral pills anyhow, so you give them injectable, but they have to come in, they have to take it there. The vast majority of the HAT program is observed treatment, right?
Yes and no. If you enter heroin-assisted treatment, usually most people who will do so receive injectable heroin-assisted treatment under supervision, meaning that they will have to come in 2 to 5 times a day to receive or to inject the pharmaceutical heroin. So there's no take-home at the beginning of treatment. But this can actually change if a patient stabilizes enough in treatment after a certain period of time. We have relaxed regulations in the past years, so there is now take-home for up to a week of pharmaceutical heroin for injectable purposes, but also as tablets.
Now, so, I think when we previously talked about it, you're quite careful, though, when you do it, right? Because you are concerned about the possibility of diversion, and you have to have a therapeutic relationship. And how long do the doctor have to be in a relationship with the patient before they start doing this?
The federal regulations for heroin-assisted treatment stating that it has to be 6 months. But for oral opioids such as methadone or buprenorphine, there's no such period. So it's up to the discretion of the prescribing physician. But you're absolutely right. There's time to build up a relationship between nurses, between doctors and the patients. And then when the patient is sufficiently stable, we provide them with take-home. But to the start of treatment, it's always supervised.
Okay, and now can you talk a bit about what happened as a result of starting heroin-assisted treatment in Switzerland? My understanding was before this, there was drug parks in, I don't know, was it Geneva or Bern, or but there was a big problem: the open use of drugs, open consumption of drugs, needles in the park, the kind of thing actually we're witnessing here. And my understanding is with the Swiss model, you basically eliminated the drug parks and you greatly decreased the public consumption and use of drugs. No, am I right?
You are completely right. There are no open drug scenes anymore. Last year, they have sort of really opened up because of crack cocaine, but this is a different issue. And in terms of heroin and opioids, we do not have an open drug scene. We have no public use. So this is not a problem. And this is, I think, attributable to heroin-assisted treatment and the massive scale of heroin-assisted treatment that I hinted to in my opening statement. And the other thing is we also introduced other services such as supervised consumption services, housing, things like that. So there are several measures, but I want to point out that all of these measures, it's a complex issue, we heard that today, have to come together. And one major part of it, as a physician, I think, is treatment.
Thank you, Dr. Vogel. Thank you, Dr. Pawlowski. Next, over to Dr. Ellis, please, for 5 minutes.
Thanks very much, Chair. You know, I'd like to continue on the route that Dr. Pawlowski was on, and I think it's important to correct some misconceptions here that we've heard in this committee. You know, for instance, opioid agonist therapy and witness dosing, as Dr. Pawlowski talked about, obviously is not the same thing as not having a therapeutic relationship with an individual who uses drugs and simply sending them home with 30 tablets of 8 milligram Dilaudid. And Dr. Vogel, I guess I'll start with you, sir, if I could. During your time in participation in the Swiss model, was that type of safe supply ever trialed in Switzerland, just giving patients 8 milligram tablets of Dilaudid in significant quantities?
No, as I pointed out, we have the possibility of treatment, and we have the possibility of doing take-home to patients that we as physicians deem stable enough. But I also have to point out that these take-homes, this is actually what the majority of patients receive in Switzerland now. But I want to also make clear it's part of a treatment, it's part of regular and scheduled contacts with a physician, and it's not outside of treatment.
So clearly, Dr. Vogel, these patients would have more than just a prescription or free, very potent opioids. They would have access to therapy, housing, and other supports, as you mentioned previously.
I would say it's a spectrum of therapy that is available, and on the very basic end of opioid agonist therapy is the provision of medication. But as I pointed out, I think a lot more has to be offered in this therapy. Like you said, housing, but also psychiatric treatment of concurrent psychiatric disorders, and other options. And I want to make clear, like I mentioned, I know that you're a physician, right? You're a general physician, and a lot of the treatments here are done by general physicians. But those are the more stable patients. They have a long, ongoing relationship with their GP. That works fine, and you can do take-home for most of them. It will work fine. But we also have specialized institutions that are responsible for the, let's say, the patients with more problems, with the psychiatric problems, with comorbidities. And we also have a large scale of these institutions that treat about 45% of patients. But the rest is treated in GP practices.
That Canadians, I think it's important out there that the Canadians understand that those treatment beds do not exist. Those other supports do not exist in Canada. And I think the other important point is realistically giving people who are actively struggling with addiction, simply giving them as I said, Dilaudid 8 milligram tablets, 30 of those at a time, realistically amounts to palliative care. Please go out and use those as you wish, or sell them in a diversion manner. And we also know that that's not terribly helpful. Certainly, the model that you're talking about in the parlance of here in Canada. Historically with methadone, we would understand that people develop a therapeutic relationship with practitioners and then have that ability for, as we call it here, carries or take-home doses when they become more stable in their addiction and have that therapeutic relationship. I think one of the other things, and certainly I know you'll correct me if I'm wrong, but fentanyl has not been a significant problem in Europe. Is that a true statement, Dr. Vogel?
I wouldn't say for all of Europe. There's countries where it's a problem, but in Switzerland, it's not. It hasn't been a problem yet. We have nitazines just arriving on the scenes, which are similarly potent to fentanyl or more potent. So we will have to adjust our treatment, and this is what I pointed out in my last comment. That I think where there's no evidence, you have to collect evidence. This is something that the Swiss did as well. They did a large study on heroin-assisted treatment, which showed that it worked and was cost-effective. And this is probably something that we would do if the nitazines arrive on a larger scale, is that we would start treating with higher potency opioids like fentanyl, because we know that methadone is not a good medication for many patients, and patients need to be able to choose from a variety of available substances. And heroin is among them, pharmaceutical heroin, and it's very strong. You can inject it. But maybe even for patients with fentanyl use, maybe even this is not enough, and we have to provide fentanyl for these patients in the context of a treatment.
Thank you, Dr. Vogel. Thank you, Dr. Ellis. Next, Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair. Thank you, all the witnesses, and my sincere condolences to Ms. and Mrs. Hedican about your loss of your son. My question is to you here first. Can you talk about the stigma around those struggling with addiction, and what kind of the programs do you think you can run about so they can they're designed about the awareness first, and then if someone has a problem, how they can use the harm reduction, that pathway.
Illegal and criminal are tied to substance use and addiction, we will always have stigma. It can never be removed. And until we start educating our kids better about the harms of substance use and acknowledging that the gateway drug alcohol starts that path. As a recovering alcoholic, I never would have tried cocaine if I hadn't have been drunk out of my mind. And all of my friends that did hard drugs were drunk first. But we don't acknowledge alcohol as the gateway drug. Go ahead, Sudhi.
I wish I'd written down your question. Can you ask it again, please, Sonia?
Stigma, and then before using the drug, how can we raise the awareness? So do you think in this school, and then what should be done maybe in the social, organizations? What need to be done?
Two things I'm really passionate about. I believe there has not been enough research looking into the neurobiological components and treatment methods for it. Research for addiction has been really low. As we said in our speech, it's like the model for AA is based on just don't use, but we would never say that for anybody who has cancer or diabetes. Just don't eat the sugar and then you won't have a problem. We look at all different ways to, so I would say research really needs to be improved. We have shared Ryan's story in a PowerPoint with schools, nurses, all sorts of people to understand that it's not a choice, educating people, reducing the stigma that to consume a substance does not mean you are a bad person. People that smoke cigarettes are addictive. Nicotine is highly addictive, and there are some treatment methods that are medical, but nobody ever now shames people who smoke. So if we can present it from the medical perspective and the neurobiological components of what's happening, and let people know that substance use is a normal thing that has been happening. How do you have healthy relationships within yourself? How do you acknowledge when your consumption of whatever your choice is not healthy, and then to understand where to go to get help. Our doctor was not able to provide help for Ryan when he needed it, so it's not just education of users, but it's also education of those people that provide support to understand. People don't choose to be addicted, but I also want to talk about, I feel the media portrays people that use substances as people that are causing difficulties. It's very visible right now, are unhoused. That's not the vast majority of substance users. Those users cannot support the billion-dollar industry that organized crime has. There are so many other substance users, and we don't acknowledge that. Sorry.
Thank you, Ms. Hedican. Sorry, I have to go to Chief Tong. Chief Tong, you talked about the collaboration, health and social services, and public safety. Pathway to care for an individual with substance dependence, and emphasize the need for resources to direct people to treatment. How many arrests the police make for the public who are using the public drug use?
I can tell you in our jurisdiction, the charge of possession of a controlled substance for the last few years has whittled down to nearly a fraction of what previous years have seen. And although we haven't decriminalized the possession of controlled substances, specifically individuals using in open spaces by de facto of not engaging, not arresting, and not not engaging when appropriate, we have seen by de facto a decriminalization of possession of a controlled substance. And we see the impacts that is happening in our community right now in London, that if we don't address it, then we're causing some serious harm, and it's impacting businesses, communities, and the greater community as a whole. So ma'am, you're citing comments that I've made in the community before our police service board, before city council, and I will just reaffirm to you that we've listened to the community, and it's about balance. And we need to ensure that we have balance, and that when appropriate to do so, especially in the context of impacting the greater community as a whole, police officers have to have the ability to engage. And we're looking at engaging in an effective way with our community.
Thank you. Well past time. Monsieur Thériault, pour 2 minutes et demie, s'il vous plaît.
Mr. Thériault, you have 2.5 minutes. I have a question for Ms. Brière-Charest, but first, I have a bit of an issue with what I heard from the chief of police. I'll just let him put his earpiece on. Hopefully this won't be a part of my time. You talked about decriminalization. You're an expert in law enforcement, and I'm sure you understand legalization, decriminalization, and dejudicialization. Now, you've stated that when people use substances in an inappropriate location, there's no municipal law that allows you to act because of decriminalization, but decriminalization is for simple possession, not I feel like that's what you stated.
Thank you for the question, sir, and Chair, through you. I missed some of that translation. My apologies, sir. So if I understand you correctly, what I actually said was in Ontario, in London, it is still illegal to possess and use controlled substances in our community. But by de facto, we have not, our police service, we have not been engaging individuals who are using in open spaces, because we have taken a very, we've taken a position of compassion. We've taken a position with the principles of the changes in the Controlled Drugs and Substances Act, where officers are looking at alternatives other than to arrest.
Mais je comprends ça. Je veux clarifier.
I understand that. So it's dejudicializing in a way, but a chief of police can't say to his officers, if somebody is infringing upon bylaws in a city, you have to act. That doesn't have to do with decriminalization or compassion. This is simply respect for a public space. So if I'm drinking champagne at the entrance of a hospital and I'm smoking a pack of cigarettes, the police will react. That's not linked to our issue here. Why are police officers not reacting for these cohabitation issues with people with substance use disorders and respecting basic rules in cities?
Response, please. He's well past time.
That's not what I'm saying, sir. What I'm saying is, in previous years, our officers have not been engaging, and they've been taking a compassionate approach. And what I've stated publicly is that we've listened to the community. It is still illegal to use controlled drugs, controlled substances in public, and we are looking to enforce our position of arrest when appropriate.
Thank you, Chief. Next, Mr. Johns, please, for 2.5 minutes.
To Mr. and Mrs. Hedican, can you speak about your advocacy for evidence-informed policy approaches to the toxic drug crisis, and what motivates you to speak out about this increasingly politicized issue? And I'm going to add a second question in here because I've only got 2.5 minutes, so I'll give you time to respond. Has witnessing the incremental approach that all levels of government have taken and the increasing politicization of the toxic drug crisis, has that made your grief journey even more challenging?
Just gets bigger with each day. Because there isn't anybody in here talking about the people that aren't addicted, the kids that are dying. It's like they don't exist. It's the people that aren't ever going to go to recovery that are dying, that don't exist to you. And I don't understand how you can ignore these lives that are being lost, thousands, and will continue to be lost. It's like they don't exist to you. You're failing at your responsibility to protect all Canadians. And it's a gut punch every day to know there's 5 to 6 to 7 in BC and 22 in our country, and a majority of them are not, you're not dealing with it. You're not acknowledging it. It's a gut punch. Our government is failing at the responsibility. And we need to quit talking about atrocities in other countries because there's one in our goddamn country. There's 22 people are going to die today. And a majority of them are not addicted. And they're not talking about safe supply. And you're not acknowledging it. And until we deal with the toxic drugs supplied by organized crime, you're failing at your responsibility to protect all Canadians. Do your jobs.
Well, I don't know if this would be a time. I actually would wonder with Dr. Vogel if you had a toxic drug supply problem when you implemented your policies.
When we implemented our policies, there was illegal heroin sold on the streets, which was our toxic drug supply. But we didn't have a medication opioid toxic drug supplies like it is now. But it was, in principle, the same illegal heroin being sold. Young people getting addicted, young people having an overdose and then dying, like you, Mr. Hedican, pointed out rightly. And we had that. And with the treatment that we offered, with all these different pillars, the harm reduction pillars that we offered, I think we had a medicalization of the problem as well. And it was very well known in also with Swiss kids and adolescents that if you start taking heroin, you'll end up in treatment. You have to go to the doctor.
Thank you.
And it's very unattractive to go to the doctor.
Thank you, Dr. Vogel. Next, Ms. Goodridge, please, for 5 minutes.
Thank you, Mr. Chair. So, Chief Trung, you said that what you've seen in London is that the so-called safe supply created a currency for people that were addicted so that they could sell it to get the drug that they were actually after. And so, would your job be easier if this so-called safe supply that was flooding the streets with potent opioids wasn't on the streets in London?
You know, I will state, and Chair, through you, I will state that I rely on the medical professionals and experts to provide their commentary and efficacy on safe supply. What we are working towards with our community partners in London is to make sure that there is mitigation of diverted hydromorphone.
So if less drugs were diverted onto the streets in London, would your job be easier or harder?
If less drugs
Were being diverted onto the streets in London, would it be easier or harder for you to do your
Well,
job?
I can tell you that's what we are aiming for, so that there is no diversion of hydromorphone into the community.
Fantastic. So you talked about a little bit about there was a de facto decriminalization because you guys were not engaging with people that were using drugs in open spaces. Has the London Police now started to engage with people using drugs in open spaces?
Police service is looking at a comprehensive strategy with community, with health professionals, with social services to look at a stronger initiative and strategy to deal with open drug use in the community. In previous years, officers were looking and understanding that drug consumption is a health issue and a health concern, and they were using their discretion accordingly. We have seen the results of that. We have seen and heard from the community, and we're seeing impacts that are impacting the community as a whole. So we're looking at a different strategy to engage when appropriate.
Well, I know, so I went to London, I was actually like 7 months pregnant back in April of 2023, and I was shocked by the amount of open drug use that was so visible from downtown London. In fact, I watched a drug deal happen in front of the CBC headquarters, which then told me that perhaps I wasn't in a safe part of London, just to find out that it probably had been safe 9 years ago. So what have you guys changed from a policing standpoint, or what barriers are in the way from a policing standpoint for you to actually deal with the open drug use in London?
Well, some of the challenges is that we understand that drug addiction is a health problem and a health concern, and there are determinants that are creating this environment for people to be in this space.
Are you allowed to charge for simple possession of drugs?
Absolutely we are.
Do you charge for simple possession of drugs?
And this is what I've been saying. In the last few years, ma'am, our officers have dramatically reduced their enforcement efforts with possession because we understand that it is a health problem. We are listening to the community. We are also abiding by the principles of the Controlled Drugs and Substances Act and making sure that if we arrest, it is because there's a public risk.
So I fully agree. It's a health concern and it needs to be dealt with as such. Have you seen any increase in the amount of detox available in the City of London?
I have not.
Have you seen an increase in the amount of addiction treatment available in the City of London? So the government decided to roll out a dramatic new program, and you haven't seen any increase in detox. Have you at least seen some increase in treatment?
I would say that London, like many other municipalities, require support and funding for treatment options.
So do you think the federal government failed rolling out a radical new program and not providing any support for the medical side?
And again, I'm not going to answer that question.
Fair enough. So there's no new detox, there's no new treatment. So if you were to arrest someone with simple possession for open drug use, what would happen?
Right now, our option for our officers, if we were to arrest based on the circumstances, our officers have the availability to arrest, seize the drugs, release unconditionally. The second option our officers have is to arrest and charge when appropriate and seize those drugs according to evidence. and putting those individuals or that individual before the courts. What we recognize is that we only want to put them before the court when it is appropriate, and sometimes circumstances it is necessary to put them before the courts. And in some cases, putting them before the courts is actually an opportunity for them to receive care in that capacity. A lot of the times, if our officers are engaging, and we were looking at this right now, is there other options for community to be involved and engaged and support that individual? There's circumstances where our officers have to engage for public safety purposes, and circumstances will dictate either court or other avenues of care.
Thank you, Chief Trung. Next, Dr. Hanley, please, for 5 minutes.
I want to thank all the witnesses today for some really important testimony. Dr. Vogel, I would like to start with you. I would guess you're familiar with the 2008 Naomi trial, which attempted to assess who would be the best candidates for heroin-assisted treatment in the Canadian context. And just briefly, that study quoted that long-term chronic opioid injectors with severe health and social problems and several previous addiction treatment attempts would be among those candidates. It also pointed out that the participants are largely polydrug users, with cocaine being the second most popular drug of choice after heroin. That of course, was 2008, so times have changed. But I would venture that this remains, as you, I think, suggested, that this is an underused treatment in Canada, and it's a struggle to get funding and general support for this treatment, as well as local production, as in the case of Fair Price Pharma in the downtown east side. Does this patient description match who is accessing treatment in Switzerland, and what do you think we are missing in our approach, apart from perhaps a massive scale-up in this treatment?
It pretty much is the same kind of clients or patients we have here, which is the reason for this is that the Swiss did a trial on this, and the inclusion criteria of the trial we did 30 years ago was basically replicated in every other trial, in every other setting, without ever asking whether this does make sense or not. There's one trial that has looked at patients who have not fulfilled these criteria, which means they have not failed previous treatments, they have not had methadone before, and it worked equally well. That's the German trial. That works equally well. I can assure you, I am absolutely, there's no evidence for what I'm saying, but I'm absolutely sure that every patient with an opioid dependence has the possibility to benefit from heroin-assisted treatment, regardless of whether he failed treatments before or not.
Thank you. And you did mention buprenorphine or Suboxone in passing in answering previous questions, but I wonder if you could just elaborate a little bit on where Suboxone is in your treatment regimen in the Swiss context.
Buprenorphine is available here. It's available not in combination with naloxone because that was never prescribed, never used. It was taken from the market. We use it in approximately 10% of patients. The reason for this is that patients can choose from a variety of different substances, and they will more often than not opt for another substance than buprenorphine. Buprenorphine is a so-called partial agonist, which does not have the full effect, and most patients are not looking for this effect in their treatment, and they're not treated adequately, to my personal experience, with buprenorphine. Although, if you look at the evidence, the randomized controlled trials say different, but this is not real-world evidence, I think.
And just very briefly, and thanks, that's very helpful, but just very briefly, inhalable heroin, you mentioned oral and injectable. Is there an inhalable agent that's available in Switzerland?
We're currently investigating nasal pharmaceutical heroin, which is atomized into the nose. We're doing that because we have people that do not inject but are severely addicted, and we also want to offer a risk-reduced option of receiving pharmaceutical heroin. There is inhalable, so-called smokable heroin in the Netherlands. It works fine. It's another option. Like I said, you have to have a range of substances, but you also have to have a range of routes of administration in order for treatment to reach maximum efficacy.
Thank you. And for the Hedigans, I only have a minute left. But I just wanted to add my condolences, not just for your son Ryan, but for your nephew Justin as well. And I'd love to learn more about their lives and what their losses, among thousands of others, have meant for our families and our communities. I'm not sure if you've seen some of the testimony from previous meetings where other parents with equally tragic losses have come with completely different views. So when you hear aggrieved parents who share your anger, but who direct their testimony in a completely different place, how do you think we should treat this testimony as committee members?
We're not talking about people that aren't addicted that are dying. And I don't understand that. It's nobody is asking the questions, how do we save the people that aren't addicted, first-time users? I don't understand. There hasn't been one question to that. And the only way is to address the toxic supply of drugs. And shame on all of you for not asking that question. Kids, the first-time recreational users are dying, and you're not asking, how do we save them? You're talking about a small percentage of chronic users. I'm honestly, I'm disgusted. It's, sorry.
Thank you, Mr. Hedigan. Dr. Ellis, please, for 5 minutes.
Thanks very much, Chair. I'd like to talk to you, Dr. Vogel, a little bit about perhaps what Mr. Hedigan is maybe referring to. I think there may be another way to look at those so-called first-time users. But realistically, we haven't discussed much in this committee with respect to prevention. And I wonder, in your experience in Switzerland or perhaps in Europe in general, if you've had any opportunity to look at that specifically.
Well, I'm not an expert on prevention. I'm an expert on treatment. But what we in Switzerland think has been, we have very, very few young people initiating opioid use. And we think part of it, and that I tried to explain that before, is that the scale up of treatment has made very clear that it's quite dangerous to use opioids. There's a high risk you'll overdose. There's a high risk you'll get addicted, and a high risk you end up in treatment. I'm not sure whether that can be said for Canada with the treatment option I'm aware of, but in Switzerland it's very clear. If you have opioid addiction, you have to go into treatment. This is very, very unattractive. We are sure that it's part of what has been preventive. What has also been preventive is that obviously less opioids are being sold on the streets because we provide more effective treatment than is done in other places. That's what I can say. And I also think that most adolescents are aware of the dangers, and they could probably assess, probably get like codeine, things like that. But there's no, it's harder to get, for example, pharmaceutical heroin on the streets. That's clear.
Another question, and I realize it's not your area of expertise, but are precursor drugs for the creation of things like fentanyl, etc., are they legal or illegal in Switzerland?
Most precursor drugs are illegalized once they pop up. That's the way. Once the system recognizes the substances, they are scheduled.
Well, do you have any idea how long it takes to make them illegal, the precursor drugs?
I do not.
Thanks very much for that. You know, one of the interesting things, of course, is as we talked a bit about, that in Switzerland, fentanyl is really not a so-called drug of choice. which perhaps does make the Canadian environment a little bit different. And I think that bears repeating. I think the other things that are incredibly important are that the scientific studies that have been done with respect to treatment are all really based on witness dosing or at the minimum, or indeed opioid agonist therapy. And certainly your idea around saying there are a requirement for a multitude of different substances that will help tailor treatment uniquely to the individual. And I think we know here in Canada that certainly methadone has fallen out of favor, although it's been used in treatment for a very, very long time. As we look at, as Mr. Hedigan talked about, that the NDP Liberal government is failing at its job here, having presented certainly safe supply without any supports to go with it, it's a travesty. And as we begin to potentially looking to form the next government, we really need to look at other things in terms of prevention and resilience, continued disruption, and quality rehab. And we know that those kinds of things, coupled with obviously with housing, is really something that Canadians need to begin to wrap their mind around, to say, how can we actually make the system better in Canada? Dr. Vogel, do you have any final words on how we might improve things here in Canada? And if you're not familiar with the system here enough to comment on that, that's fine.
Maybe let me I heard a lot about witness dosing, and yes, witness dosing has its place, but I also want to point out that it's very hard to keep up a life, manage a family, and keep in a job if you have to appear at a treatment center 2 to 5 times a day. 6,000 times a year. So I want to point out that take-homes are very important, and the majority of patients here receive take-homes. So it's actually quite a liberal treatment, and I would advise Canada to abolish unnecessary rules and regulation and put more responsibility in the hands of physicians and people who use.
Thank you, Dr. Vogel. Next, over to the Liberals, Ms. Kayabaga, please.
Thank you, Chair. I'm going to go straight to the Chief. Based off of some of the questions that you've received in our committee, and as well as the comment that you made around not being able to arrest our way through the crisis, and given the context of our community, the City of London, that has experienced many of these overdoses over the last decade, as well as even in places like the jails. I'm curious to know if today we were to remove the current crisis of toxic drug use off the streets, do you think there'll be other drugs that will pop up on the streets?
Thank you for that question, and Chair, through you, yes, I do. With organized crime, it's about profit, and it's about exploiting individuals for gain and profit. And there's no question that there would be additional drugs, and the war on drugs would still continue.
You're willing to continue to collaborate with the services that are available in London?
That's correct. It's very important.
And Chair, I just want to put on the record as well, someone earlier mentioned that the beds are federal responsibility, and it's not. Just want to make sure that people know that it's a provincial responsibility. And I'll let my time to Mr. Marcus.
Dr. Pawlowski, please.
Well, I think appropriately, given Mr. Hedican's remarks, I'm going to go where he wants to go, which is the casual user, right? And we haven't been addressing that. Yeah, we're talking about long-term addicts, but how about the very many people, sounds like your son, who uses on and off, but also you hear stories about somebody, one pill, and a kid or something like hockey player, and one pill and they die. I think that's really hard to deal with, to find a solution for it. I mean, I think it has to be one of our reports, but what you're seemingly suggesting, Mr. Hedican, is legalizing it, safe supply. Okay, you go and you buy your booze, you buy some narcotics there too, but it would have to be cheap enough, right? Because like with marijuana, there's still a black market for marijuana because it's cheaper on the street than it is in the marijuana stores. So similarly with narcotics, there'd be a black market, so you'd have to make it cheap. But then wouldn't you run the risk of people like my kids who you know, okay, I'm going to buy beer, maybe I'll buy some narcotics. I mean, it's and then you get addicted to the narcotics, and you create a bigger social problem with this large population of addicted people. I don't know. I mean, that's kind of. But I mean, if you have suggestions, like this is a really important topic. So I give you the floor, probably the last few minutes.
100%, that's reality. We don't have a choice whether we want drugs in our community. The only choice we have is who controls, government or organized crime. And yes, someone may try another substance because it's for sale next door to the liquor store, the gateway drug that we put on every corner. And people are always going to try drugs. And the vast majority is after they've drank. So that's just reality, and we're not addressing reality. And the reality is that as long as we have alcohol, and people use substances and alcohol for different reasons, people are going to try drugs. So I'm repeating myself. So it's either organized crime or government. And we can see today we've got over 80 years of evidence of how it's working out with organized crime, and it's never going to change. So
I agree with you, and I've got sons, and they go to parties, and there's alcohol, and I always tell them, like, if there's drinking, like if there's drinking and people have drugs, just leave, because after a few drinks, you're going to be tempted to do it. Like, do you have any other suggestions with that combination? Because yeah, I think a lot of times people first try it, or when they're drinking, and they say, like everyone's taking it, I'm going to take it. Next thing you know, they're overdosing.
And they die.
But how do we educate kids with drinking and drugs?
As I said earlier, it has to start at a young age. It has to start in elementary school, and it has to be on a regular basis. And it has to be by, I believe, people like myself, people of lived experience. And we have to acknowledge, and we don't, because we put alcohol in shiny stores, and we have commercials, and we glorify it, and we've normalized it. It is the danger drug, 100%.
There are more people with alcohol problems than there are with cancer. That was the Surgeon General from U.S. And we don't, that's one of the things, I'll go back to, what do we need to do? We need to talk about realities. In 2016, when Ryan was waiting to get into the last door, we needed to find him heroin until he could be able to detox. And there were about 43 drug houses in our community that the police had said, you don't see it, so you think it's not there. Because it's there doesn't mean you have to use it. It is already there. It's in all of your neighborhoods. And it's not in just what you think of as a drug house. It goes all the way through society. And yeah, that's where my heart started. I didn't want any of my children to use substances ever. That's not reality. And then so even that stigma of, I saw a drug deal. Oh, well, how about you're like, okay, I saw somebody getting what they need. No stigma, move on, rather than I saw two people holding hands that weren't the same sex. Oh, like,
Thank you.
Move on, educate yourself.
Thank you, Ms. Hedigan. We're at the appointed hour. Mr. Johns has asked for one final question, so I'd like to extend that courtesy to Mr. Thériault and Mr. Johns, and then we'll seek a motion for adjournment. Monsieur Thériault, une question, s'il vous plaît. Oui.
Monsieur Thériault. Ms. Brière-Charest, can you talk to us about the continuum of care for substance use? In Quebec, we have a well-established network, and we have a consensus even in the different organizations and with frontline workers and for prevention, research, treatment. There is a diversity of resources that are accessible. Regarding harm reduction efforts, I can speak personally on this. On the last overdose that I saw was a case of somebody who was not addicted and who still required 3 doses of naloxone and required our support and likely would have died outside in the streets overnight. And so it is essential to maintain these services for people who are at risk and that we increase our prevention efforts as well. Thank you, Mr. Thériault.
Madame Brière-Charest.
And Ms. Brière-Charest.
Mr. Johns, please.
Spoke about their son losing his life when he relapsed after 8 months of sobriety. And we know that people who have substance use disorder, that it's a relapsing, recurring disorder. How do you in Switzerland ensure that people get drug replacement therapy and what substances they get when they do relapse, when they decide that they're going to use? And I know you're not going to be able to answer about first-time users because you're an addictions doctor, but could you speak to that and maybe some advice to us on what we're dealing with in Canada and how to respond?
Well, I didn't get the first part of the question because it was cut off, but if someone relapses or uses in general, we would try to would try to offer treatment first of all, and we know that abstinence-based treatment is not working for 95% of the people. So opioid agonist therapy is the best we've got right now. And we would offer that. And if people relapse on opioid agonist therapy, I would offer them an improvement in therapy. I would try to offer dose increases. I would try to offer a different substance or a different route of administration. And if I notice that a patient will relapse, for example, on methadone or buprenorphine, and again, I will offer, for example, heroin-assisted treatment as a more intensive and better treatment offer than I had tried before. And I will also see that what I have been offering right now is still failing the patient, and I have to improve, and together with the patient, find something that is acceptable and works.
Thank you, Dr. Vogel. Thank you, Mr. Johns, and thank you to all of our witnesses for being with us here today. The variety of lived experience and expertise has made for an exceptionally interesting meeting and testimony that will be extremely valuable to us in our report back to the House. Is it the will of the committee to adjourn the meeting? Yes. We're adjourned. Thanks, everyone.